Welcome to NAPNAP's microlearning segment on pediatric RSV prevention. I'm Christine Butler, a pediatric nurse practitioner practicing in Charleston, South Carolina. This brief segment will provide an overview of the current practice recommendations for RSV prevention with nirsevimab, addressing who should receive the monoclonal antibody, the recommended dosages, and how to handle the current supply issues. Firstly, let's discuss nirsevimab, which was approved in July 2023 under the trade name Beyfortus. It's a long-acting monoclonal antibody for passive immunization that's expected to reduce the risk of severe RSV disease by about 80% among infants and children. We've all heard of Synagis, which is also a monoclonal for RSV. However, the main differences between the two is that protection from nirsevimab is expected to last 5 months, providing infants and toddlers with protection for an entire RSV season. And it's been FDA approved for a much wider population, including the following. For all infants entering their first RSV season who are 8 months or younger, a dose is recommended. The typical RSV season would be October through March. For that first RSV season, the dose is going to be based on weight. 50 milligrams is recommended for infants who weigh less than 5 kilos. And 100 milligrams is recommended for infants who weigh equal to or greater than 5 kilos. For children 8 to 19 months who are at increased risk of severe RSV disease, a dose of 200 milligrams is recommended when they're entering their second RSV season. Of note, nirsevimab is supplied in single-dose prefilled syringes of either the 50 milligrams or 100 milligrams. So now we find ourselves mid-RSV season. Parents have heard about this wonderful monoclonal antibody, but we can't keep it in stock. Dr. Mandy Cohen, director of the CDC, said recently on an interview that there is greater demand for nirsevimab than any vaccine in child history. We know we have a shortage. The number of doses needed was underestimated, and the supply is not expected to improve much this season. However, better stock is anticipated for the next RSV season. In the meantime, if you find yourself in a situation where you don't have enough doses, how do you prioritize? Thankfully, the CDC has our back and has released interim recommendations to guide prioritization of doses that we do have, with the goal of protecting as many children as we can this RSV season. I'll now briefly highlight those interim recommendations, which can be referenced on the CDC's website. For infants who weigh less than 5 kilos, HIP recommendations are unchanged. Babies born prior to October 2023 should receive a 50 milligram dose now. Babies born October 2023 through March should receive a 50 milligram dose in their first week of life. For infants who weigh more than 5 kilos, we want to prioritize using the 100 milligram doses in those who are at highest risk, such as infants who are less than 6 months old, American Indian and Alaska Native infants who are less than 8 months, and infants aged 6 to less than 8 months who are at high risk of severe RSV disease. This would include preemies who were born at less than 29 weeks gestation, infants with chronic lung disease of prematurity, hemodynamically significant congenital heart disease, severe immunocompromise or cystic fibrosis, or neuromuscular disease that would impair the ability for them to clear their own secretions. In 8 to 19-month-olds who are eligible for Synagis, we want to use Synagis and not nirsevimab this season. If you don't have the appropriate dose of nirsevimab on hand for infants less than 8 months and they're eligible for Synagis, use Synagis. We want to continue offering nirsevimab to American Indian and Alaska Native children aged 8 to 19 months who are not eligible for Synagis, who live in remote regions. We want to reserve 50 milligram doses for infants who weigh less than 5 kilos. In other words, we want to avoid using 2 50 milligram doses for infants who are over 5 kilos when they could have a 100 milligram dose. Encourage pregnant women to receive the RSV pre-F vaccine Abrysvo from 32 to 36 weeks of gestation. And we want to use either the Abrysvo in pregnant moms or nirsevimab in infants. Administration of both is not needed in most babies. In summary, nirsevimab has been approved for the prevention of RSV lower respiratory tract diseases in infants born during and entering their first RSV season, and in children up to 24 months of age who remain vulnerable to severe RSV through their second RSV season. Although shortages exist, the CDC has provided recommendations for the judicious use of the monoclonal antibody to help us through this first RSV season. Thank you.